Shall I start? 60-year-old male presented with complaints of severe central chest pain, retrosternal, associated with sweating, radiating to back for the past 2 hours. On arrival, patient is conscious, oriented and diaphoretic. Airway patent, no pooling of secretions, talking in full sentences. Breathing saturation is initially 98% in room air. Respiratory rate of 24 per minute and chest air entry bilateral equal with the bilateral basal crepitations. Circulation BP is 120/80, pulse rate is 88 per minute. All peripheral pulses are palpable. GCS is 15/15, pupil bilateral equal and reactive. Exposure temperature is febrile. GRBS is 154. As a primary adjunct, we took ECG initially, which shows ST elevation in 2-3 AVF with reciprocal depressions on 1 and AVL. And we took point of care CBC CRP also, which shows total count 6,000 with platelet count 2,60,000 and HB of 10.9 and CRP of 4.2 and VBG. No electrolyte abnormalities. Creat is 1.2 milligram per DL with lactate 2.3.
You got a patient who presented you with central chest discomfort. In your primary survey, you are telling that he is having mild bilateral basal crepitations. And you took a ECG which showed 2-3 AVF ST elevation with the reciprocal changes in 1 AVF. What is your next 3 orders? You have done your orders. Okay, you have done the orders. You have done a CBCRP, you have done a VBG, and I would have done one thing more. Why? What are the things that you are doing? Why did you take VBG or ABG? Doesn't matter. What was the saturation?
Saturation is initially 98 with
98 without oxygen.
In room air.
In room air. So 98 without room air, in room air. That's why you took a VBG. Okay. Why you took a VBG?
To know the basal values of lactate, creat values.
Lactate, creat, and okay. Is the patient in shock?
Initially, BP is 120/80. Patient is hypertensive also. We don't know whether.
What is the heart rate?
Heart rate is initially only 88.
88. So if the patient was in shock, what will be the
Tachycardia will be there.
What will be the only question you will be asking the patient if the lactate was, if at all this lactate was around 4.5, what will be the question you will be asking? Heart rate of 88, lactate is 3.54. Okay. PP is 120/60 for a hypertensive patient. What will be the question you need to ask?
We will check for any other causes for lactate elevation if you are not suspecting any shock.
You told you want to know lactate for shock. So you suspect a shock. Shock will have tachycardia.
But
this patient has lactate elevation, no tachycardia. Hypertensive, but be on the lower side. What is the one question you need to ask the patient?
Beta blockers.
That is the question you need to ask, not look for other causes of lactate elevation. Question is, are you taking beta blockers? Isn't it? Beta calcium blockers, that history should be taken out. Okay. That is VBG. What is the only thing you are concerned with CBC? HB. That's the only thing in this case you are concerned with HB is this patient simultaneously having an anemia which is going to complicate MI. How it will complicate MI?
Cardiac failure.
It will cause more ischemia. Since myocardial oxygen demand will be high, cannot be met because of anemia, will push the patient into heart failure and possible shock. That is the only thing that you are concerned in CBC is hemoglobin. Okay, what is the next order? After seeing that ECG?
After seeing ECG, we have to give...
No, after seeing that ECG, 2-3 AVF
right
ST elevation. Right side ECG.
Right side ECG is taken.
What was there?
No changes in the right...
No changes in right side ECG. What does that mean?
Right ventricular is not involved.
Then where is the infarct? 2-3 AVF ST elevation?
Inferior.
No. Where is the infarct? RV is not affected.
So
you want to take a right side, any 2-3 AVF ST elevation ECG you get, you want to take a right side ECG to know whether you are dealing with a RVMI, not inferior wall MI. The moment you see 2-3 AVF ST elevation, you know it's a inferior wall Then your question is it a inferior wall right ventricular MI or not? That's why you take ECG on the right side. So what are the ECG findings that will predispose a patient, a 2-3 AVF ST elevation patient? What are the ECG findings in which you should suspect there will be a RVMI? Lead 3 more than lead 2. ST elevation in lead 3 more than lead 2, and ST elevation in? Obviously, but you want to take a right side ECG, no? So what in left side will you predispose? One is lead 3, ST elevation in lead 3 more than lead 2. Then V1. V1 ST elevation, if it is there without V2 involvement, you should suspect RVMI. You should take a right side ECG. And when you take a right side ECG, what will you look for? We look for V4. Right side V4 lead, in that lead whether there is ST elevation. If that ST elevation is there, you can say this patient is having a right ventricular MI. Why you want to know whether it's right ventricular MI?
The management difference is that of flow.
What is the management difference between right ventricular MI and left ventricular MI?
Fluid can be given in case of right ventricular MI.
You want to give fluid? What will happen if right ventricular MI occurs and the right ventricle fails? What is the job of right ventricle?
To pump blood into the lungs.
Into the lungs, and where will that blood go?
Finally into the left side of the heart and to the systemic circulation.
Preload of LV is the systolic volume of RV. So if RV fails, patient will go into biventricular failure. So in the RVMI, you are giving fluids because RV's systolic volume should not diminish. If it diminishes, patient will go into biventricular MI. Okay. In LVMI, you are not giving fluids because it will cause increased strain to LV, causing fluid overload in the lungs and pulmonary edema. Okay. So in that condition, you want a preload reduction and afterload reduction. You want to preserve LV's pumping function. In RV, if RV fails, it should not be secondary to a volume deficit failure. If it is a volume deficit, patient will go into biventricular failure. That is the most important thing why you want to know whether it's a right-sided MI, RV MI or not. Okay. So you took a right-side ECG. ECG is not having any right side V4 ST elevation. So where is the MI?
Left ventricular inferior wall.
Left ventricular inferior wall. Where is the MI?
Occlusion
Which
is in the right.
artery? Left?
Right coronary.
Right coronary artery is right ventricular MI. Left circumflex. Left circumflex artery is the culprit artery. So left ventricular inferior wall is supplied by left circumflex artery. But that means patient is going to have a left ventricular infarct. That's what. That's the main thing that we are going to understand from this. So we are going to reduce preload, reduce afterload, and give the standard MI care. Okay. So what and all you did. So this is your primary adjuvants, right? So this is become positive. This is now ST elevation MI. A inferior wall, non-RV, ST elevation MI. What is the next? Once you diagnose MI, what is your next diagnostic concern?
With or without cardiac failure.
With or without cardiac failure. That is the correct answer. With or without cardiac failure. How will you know? What are the stages of cardiac failure? In MI, how do you say heart failure is there or not?
In acute heart failure conditions, there will be pulmonary.
MI, heart failure, how do you say?
Phillips classification. Phillips classification.
Phillips classification. So what is Phillips classification? What are the Phillips classes? So first is no signs of heart failure. Second is
Basal.
Mild basal crepitation, crackles or crepitations, but only in the basal segments, gravity dependent areas. Class 3 is frank pulmonary edema. In all lung fields you are getting crepitations or crackles. And class 4 is shock. So in all MI patients, your next question is, did the MI cause heart to malfunction or reduction in function is there or not? So Phillips class is the second thing. So your diagnosis should always be ST elevation MI, which area, with or without heart failure. And if heart failure, what is the class? That should be there. Okay. So this patient is already having class
2.
Class 2. This is already having class 2. Patient is already having basic crepitations. But when you say that, you have to make sure that patient doesn't have any underlying lung disorders, no ILD, COPD, no previously existing cardiac failure. All those things has to be made sure. But yes, class 2 heart failure is there. What are the further things that you did?
Initially, we look in case of MI, we initially look for heart rate and BP, whether I have to control heart rate or BP. For this patient, BP is around 120/80 and the heart rate is 88, and we give loading dose for this patient. And after that, we inform cardio and make arrangements for shifting to the cath lab. In between, after 20 minutes,
if this patient, okay, as you are saying, this patient was hemodynamically stable with mild early pulmonary edema features, you are given loading dose, you are given pain relief medications, you are given most probably
morphine,
nitrates for preload reduction and all that is fine. My scenario is, this patient, you told one thing, in MI we will first make sure that patient doesn't have hypertension or elevated heart rate. This patient has a heart rate of 110. What will you do?
we will also check for BP if it is a
BP
patient
is 120/80.
120.
Heart rate 110, BP 120/80, basal crepitations are there.
We can't give beta blockers and calcium channel blockers since the patient is in cardiac failure.
That is the correct thing. You have to understand, in MI, AHA and ACC has clearly told heart rate control is class 1 recommendations. You have to reduce heart rate. Heart rate less than 90 is the ideal goal that has to be achieved, which is equally important to preload, afterload reduction by using nitrates. Okay, so if you are going to give nitrates, AHA and ACC has told, make sure heart rate control is achieved and then start nitrates. Because you start nitrates, BP will fall very rapidly and then you wouldn't be able to give beta blockers. Isn't it? Beta blocker will be the class 1 recommendation, and if any previously coexisting pulmonary disorders are there, calcium channel blocker can be used for this. But beta blocker is a mainstay of LV failure MI condition, because cardiac oxygen demand is directly proportional to the heart rate. More the heart rate, more oxygen demand for the heart, more ischemia. Okay, fine. But it is always dependent whether the patient has heart failure or not. In acute heart failure, you should never give negative inotropic agents. So in acute heart failure, you give a heart beta blocker for this patient. Patient's inotropy will be reduced and patient will go into further failure. Beta blocker is an amazing drug for chronic cardiac failure, but not in acute events. So in this patient, even if this heart rate was elevated, you shouldn't be giving beta blocker. Then how will you control it? You need to control it, no? Evaporated. Even the question is how will you control heart rate, the answer should be what caused the heart rate. The heart rate should be either secondary to the pain, anxiety or underlying shock. Even if this patient is having 120/60 BP, patient is a hypertensive and this patient may be having a evolving shock. So first you make sure the patient is comfortable, patient doesn't have pain anymore, and pain is taken care and anxiety is taken care. If you don't think anxiety and pain is the causative factor, this patient is going into shock. You start a positive inotropic agent for this patient, this heart rate will come down. Okay, so when you get a tachycardia, you have to understand whether it's on heart failure or not. If there is heart failure and tachycardia, you should understand the heart failure is worsening. Okay, fine. Okay, so you have done all this, and after 20 minutes, what happened?
On reassessment, patient developed breathing difficulty, and at that time we reassessed airway breathing circulation. Airway still patent. Breathing was around a saturation 89% in room air with a respiratory rate of 28 per minute and chest diffuse bilateral cracks.
What was the mistake we did?
Initially, we have to start relax.
We didn't take that basal
Basal
crepitations
crepitations.
as serious. We should have understood it's a class 2 heart failure and should have started the patient on
Diuretics and
high dose diuretics and
NIV.
positive airway
airway
pressure. That was the mistake that we did. So patient went into full blown pulmonary edema. Now what has happened?
Repeat BP around pulse rate is 124 with the BP is 90-50 pulse rate, and periphery is
Why it happened?
the full means patient developed
Obviously, patient went into cardiac failure, full blown cardiac failure, class 3 Phillips class. But more importantly, now not only heart failure is there, that heart failure is now worsened minute by minute by hypoxia. Patient has gone into pulmonary edema. Pulmonary edema is now causing hypoxia. Already cardiac muscles are hypoxic. Now total body oxygen content has also come down. You understood? So now it has become a circle. Heart failure causing pulmonary edema causing hypoxia, hypoxia causing heart failure. Understood? So this is the important thing. In MI, early recognition of heart failure is the utmost importance, because MI is a ongoing condition. It's not a condition that has come, stopped and requires treatment. It is a ongoing ischemia, especially ST elevation when there is pan-cardiac occlusion. It's a complete one wall, regional wall, one entire area is getting occluded. It's becoming akinetic. It's not going to function. So if this patient develops early onset cardiac failure, you have to understand that cardiac failure itself is going to strain the heart. Is going to push the heart into tachycardia, which will again cause cardiac oxygen demand, ischemia, again heart failure. And once patient goes into pulmonary edema and hypoxia, that's a really bad situation. These are the patients we need to early institute, like high dose of diuretics, at least 1 mg per kg. Initially, if you start the infusion, after maybe like 60 mg, 1 mg per kg IV bolus or something. Initially, BP was pretty good, 120, 80 BP was there. At that time, 1 mg or even 0.5 mg per kg bolus diuretic followed by 1 mg per kg infusion and a NIV would have given the heart a bit of time to settle down. So I am not saying that pulmonary edema would have prevented, but the onset of pulmonary edema could have been pushed later. Instead of this 20 minutes, you may get some more time for resuscitating this patient. Okay, then what happened? BP went to 90-50. What did we do?
We initially started on inotropes to support noradrenaline. We initially started the patient on NORAD to support the BP, and then we started on diuretics in a low dose infusion, and NIV is also started for the patient.
Right.
Then we stabilized the BP, and patient is then shifted to CCU for further management.
Okay. What was the drug that you gave to stabilize BP?
Initially we give.
What did you start?
Noradrenaline.
Any other drug you started?
We can also start.
No. Any other drug you started? No. Norad. Why did you start Norad? What is the role of noradrenaline?
Noradrenaline is peripheral vasoconstrictor.
It's a alpha
and beta 1.
Beta 1. Beta 1 and alpha 1, right?
Alpha 1.
Beta 1, beta 2 and alpha 1. Agonists. So it will cause
peripheral vasoconstriction and also cardiac contractility and heart rate.
Increase cardiac contractility increase cardiac rate, increase vasoconstriction. These are the three main actions of noradrenaline. All three actions of noradrenaline is dose dependent actions. All three are there from initial dose itself. What is the most dose dependent action of noradrenaline? Means at the maximum doses, norad will act like a pure vasoconstrictor. In early doses, norad will have a positive chronotropic effect and positive inotropic effect on the heart more than vasoconstrictive. So now your BP was 90/50. So you wanted some vasoconstrictive action so that coronary perfusion will not be reduced. So you started NORAD and you are hoping your beta 1, beta 2 agonism will cause increased inotropic activity on the heart. That is the idea of starting noradrenaline for this patient. What was the ideal drug for this patient?
To increase the cardiac output, we can start on dobutamine, inotropes like dobutamine and milrinone.
Yeah, cardiac inotropes was the drug of choice for this patient. When we should have started? When we suspected cardiac failure, we should have started cardiac inotropic drug. What are the two main cardiac inotropic drugs that you know?
Dobutamine and milrinone.
Dobutamine and milrinone are the two really good cardiac inotropes that you have. Okay. So, what is dobutamine?
Dobutamine is beta 1 agonist action is there for increasing the cardiac contractility and
only beta 1 agonist action is there?
Beta 1 and beta 2 agonist.
What is dobutamine's effect on heart? What is dobutamine's effect on blood vessels?
Dobutamine will vasodilate heart.
So beta?
Blood vessels beta 2.
Beta 2?
Beta 1 and beta 2 agonist and
beta 1 and beta 2 agonist? Alpha action is there, no? Dobutamine? Dobutamine has beta 1 activity and beta 2 activity in lower ranges. In vasodilatory action in lower ranges with increased coronary inotropic activity. No.
Vasoconstriction is less. Beta 1 is contraction, inotropic is more. Then beta 2, some vessel constriction, then alpha.
No. So, yeah. Beta 2 activity, dobutamine causes vasodilation in lower doses, followed by significant increase in inotropic and chronotropic activity of the heart muscles on higher doses. What is the normal doses in which dobutamine is useful for the heart?
0.05 microgram per kg.
3 to 10 microgram per kg per minute. 3 to 10 microgram per kg per minute is the usual dose in which dobutamine has significant positive cardiac activity. Less than 3 micrograms is actually used as a vasodilatory action. More than cardiac activity, vasodilatory action will be there. So, if at all we are starting dobutamine, we should start at around 5 microgram per kg per minute to get a positive chronotropic activity. Okay, that is dobutamine. What is the negative effects of dobutamine? Vasodilation that we told. What else? What is the second?
Tachycardia.
Not lactate.
Tachycardia.
It has beta 1 and beta 2 activity. Because of that, there is positive chronotropic activity. So, patient can go into arrhythmias, especially patients who is having MI, patient is in severe shock, hypoxia, already pre-existing valvular heart disease patients. All these patients can be pushed into arrhythmia generation with the dobutamine. What is the drug which will cause maximum arrhythmic activity? Dopamine. So, dobutamine's arrhythmic activity is much less than dobutamine, but still arrhythmic activity is persistent. Okay. What is the second drug?
Milrinone.
What is milrinone?
Milrinone is
cyclic?
Phosphodiesterase 3 inhibitor.
Phosphodiesterase 3
Cyclic AMP
and
converted into AMP. That was prevented by
So what will happen?
there is increased cyclic AMP levels, which
Sensitizes heart muscles to
contract
by calcium.
calcium.
Sensitizes heart muscles to calcium, causing increase in contraction. Milrinone. What is the disadvantage of milrinone? What is the advantage of milrinone? It's a phosphodiesterase 3 inhibitor. It causes cardiac muscle contraction by sensitizing to calcium. What is the major advantage? No tachycardic effects. That is the major advantage that you have. So even if a patient is having a heart rate of 110, 122 to shock, you start milrinone, you don't have to worry that what will happen to heart rate. What is the negative effect of milrinone? It's a calcium sensitizer. Calcium sensitizer to smooth vessels will cause vasodilation. Milrinone will cause significant peripheral vasodilation. In comparison to dobutamine, milrinone will cause significant vasodilation. So, milrinone will be the drug of choice if patient's BP is okay. Because the moment you start milrinone, patient's preload and afterload will fall. It will cause arterial and venous vasodilation. So, preload, afterload reduction, but increase in coronary activity, cardiac contractive activity. That is milrinone's positive and negative effect. Okay. When will you start milrinone? For all cardiac failure patients, will you start milrinone? In RV failure or pulmonary artery hypertension cases, you should start milrinone because unlike dobutamine, milrinone has vasodilatory activities including pulmonary artery vasodilation. Because of that, RV filling pressures will come down. That is one advantage of milrinone. That is true. What in other cases, in normal heart failure, for example, for this patient, will you start milrinone?
In case of refractory shock, not.
In case of non-response to dopamine only, you should start milrinone. Milrinone is not the first line drug of choice for reduced ejection fraction cardiac failure. It is only after failure of dopamine in most cases. Okay, there are cases in which milrinone become primary condition, but not in all. The main thing is milrinone will cause significant vasodilation, causing shock, which will worsen patient's cardiac activity due to the shock if not properly monitored. So there is a study, cardiac failure study, CHF, Optim CHF, some Optim CHF, that is the study's name. That was comparing placebo versus milrinone. It shows that there is no improvement in mortality or morbidity in 30 and 60 days. That's how they told. Regular milrinone as a drug of choice in cardiac failure is not indicated. That's why still now dobutamine is the first drug of choice, followed by non-reactive to dobutamine, you start milrinone. Milrinone major use case scenarios are, as you told, pulmonary artery hypertension, RV failure, post-cardiac surgery patients, because myocardial stunning will be there. Because of that and all, you can start off. That's milrinone. Yeah. Anything else?
And they also told to decrease the systemic vascular resistance with the nitroprusside or nitroglycerin in dilatory action.
The thing is, when you are starting treatment with the when you are starting cardiac failure treatment with reduced cardiac failure treatment with inotropes, you want systemic vascular resistance to be on the lower side so that afterload of LV will be reduced. So if you are starting dobutamine will itself cause significant
decrease in the systemic vascular resistance vasodilation.
And vasodilation will be there. But milrinone will also contribute the same. But like in your patient, you have started noradrenaline. Now noradrenaline will cause
vasoconstriction.
increased SVR. It will cause vasoconstriction with increased SVR. So if patient is having mild heart failure due to inotropic, chronotropic agents of NORAD, BP improves a lot. Simultaneously, you will have to start nitrates to bring SVR on the lower side while keeping NORAD for its positive inotropic and chronotropic effects. Okay.